This video is on cysts and neoplasms of the kidneys. So cysts and neoplasms. And we'll start with cyst. Anytime someone thinks of cyst, they usually think of polycystic kidney disease. Polycystic kidney disease. And this is an inherited disorder. It's due to genetic mutations, and we can break it into autosomal dominant, and autosomal recessive. So what are the genes that are being mutated? The genes that are being mutated is PKD1 and 2. And when you mutate these, you have a dysregulation of things like electrolyte transport. You don't actually have to notice, but I always like to explain the pathophys. That just helps you memorize it, all right? Mutations in collagen and mutations in the cell cycle. And when you have a culmination of all this, then you get these large cystic kidneys. It leads to these large cystic kidneys. Does it only affect one kidney? No, it's going to affect both of your kidneys. So it's going to be bilateral. So we said it's broken up into autosomal dominant, autosomal recessive, right? Autosomal dominant is seen in adults. And that's easy to remember. Autosomal dominant AD, adults has AD in it. So seen in adults, and they won't be born with cystic kidneys. Their kidneys will be fine on birth, but as they grow older, as these mutations accumulate, then they start to develop kidney problems. Then they start to develop cysts. So I was right, develops later. And those cysts are gonna basically blow out your kidneys. You're gonna have chronic kidney disease. You're gonna have a mass. These are huge kidneys. The biggest one I've seen is like this big. So they're huge kidneys. You're gonna have a flank mass. You're gonna have hematuria if those cysts pop. And oftentimes these cysts mess with the vascular supply of your kidneys, so you get decreased vascular supply, decreased blood pressure. What does that activate? That activates RAS, right? So you have this uncontrolled activation of RAS, you get hypertension. And if you think all these things only affect the kidneys, you're wrong. If things affect your collagen, you're gonna have poor collagen formation elsewhere. You're gonna have poor collagen formation in your circle of Willis. So the things that are associated with polycystic kidney disease are things like berry aneurysms. It'll affect the collagen of your liver. You're going to have hepatic cyst. It'll affect the collagen in your GIT. You'll get diverticulosis, kind of like cyst of your GIT. I don't think that's a good way to think about diverticulosis, but it's easy enough to remember. So, all right, diverticulosis. It'll affect the makeup of your heart valve. So you get mitral valve prolapse. So if you just think a disorder of your collagen only affects your kidneys, that's not true. I mean, how could it only affect your kidneys? So it causes all these things. All right, causes all of these things. Now, autosomal recessive, let's move on. Autosomal recessive is found in kids. This is found in kids. And it's seen right away. It's seen actually in utero. You get these big cystic kidneys in utero, and your kidneys don't work. What happens if your kidneys don't work in utero? What do you get? You get oligohydramnios. Remember, your amniotic fluid, that little bathtub that your baby is bathing in, a lot of it is baby urine. And if you don't pee that out, then you don't make that bathtub. You don't make it that fluid. So you get oligohydramnios. You don't get enough fluid. You're like smashed against the mother's womb. And you get Potter's sequence, right? That's the malformation. That's the air malformation. There's all that stuff. So that might have been the first video together. So we're bringing it all back together. So you get oligo, you get Potter's sequence. And if they do survive, then they'll start to develop all these things, hepatic cysts, berry aneurysms, all that stuff. Now that seems like a lot of information, and anytime we see a lot of information, what do? We synthesize it all into a step-like question that helps us kind of retain the information, helps us recognize the question on the step. So let's try and synthesize all this in a step-like question. If a patient comes in, hypertension, hematuria, flank mass, you do an ultrasound, you see these large cystic kidneys. It's an adult. What inheritance pattern? What is the patient at risk for? Look for Berry aneurysms, or sometimes they might say subarachnoid hemorrhage, from the Berry aneurysms. Look for hepatic cysts. Sometimes they'll say portal hypertension from the hepatic cyst. So sometimes they take a little bit, one step further. Look for diverticulosis. Look for MVP, mitral valve prolapse. So jumble those together and make a step-like question. Okay. So that's polycystic kidney disease. Now, is all cysts in your kidneys polycystic kidney disease? No, we said that there are some other types of cystic kidneys. Back in our embryology video, we talked about multicystic dysplastic kidneys, multicystic. And then we say that wasn't inherited, that was just due to, during embryology, they didn't form correctly and they make cystic kidneys. That's right, non-inherited. Cystic kidneys. And there's another form of cystic kidneys. You can have medullary cystic kidneys. This is inherited. This is due to genetic mutations. You don't need to know what type of genetic mutations, and you're probably thinking, wait, so you have two things that are due to genetic mutations. How can we tell them apart? Well, medullary cystic kidneys gets its name because you only find cysts in the medulla of the kidneys, deep inside of the kidneys. So if this is your kidneys, you only find cysts in the medulla. That's a dead giveaway, because in polycystic kidney disease, you have cysts everywhere. You have cysts everywhere. So that's a dead giveaway right there. Also, in medullary cystic kidney disease, you have fibrosis and scar tissue, and your kidneys start to shrink, start to get small. In polycystic kidney disease, then we say your kidneys are huge. So these two are nothing alike. They're like the polar opposite. Whereas polycystic kidney disease, you have huge kidneys, you have cysts everywhere. In medullary cystic kidney disease, you have small kidneys. You only have cysts in the medulla. How could you get them confused, right? So not too bad. And then you can just have common cyst, very common. It's the name. People just develop these cysts, all right? It's nothing too unusual. It's kind of like ovaries. People sometimes just have cysts on their ovaries and never gives them a problem. No, absolutely, I was right, usually asymptomatic. And sometimes they're simple cysts where they just have a cyst. Sometimes they're a little bit more complex. And complex cysts gives us a little bit of a worry, because complex cysts have things like solid components. They might have separations, they might have septates. All right. So we're looking at these and saying, this looks kind of funky. There's an increased risk of cancer. So these give us a little bit more of a worry, and we have to kind of monitor them a little bit more. And then last cystic disorder I want to talk about is acquired cyst. Seen in patients with dialysis. People who have to use dialysis. So people that have chronic kidney disease. Why does dialysis cause cysts? It doesn't. When you have chronic kidney disease, what happens? When your kidneys shut down, what happens? You get a buildup of waste product. Your kidneys are dying, essentially. You get a buildup of waste product. And when you get a buildup of waste product, you slowly signal your kidneys to try and make more nephrons, more tubules, to try and compensate. Again, compensatory mechanisms are never complete. You never get back to normal, but it's a nice gesture. So you make more nephrons, more tubules. The problem is that when you're trying to make these extra nephrons, you can cause cysts. Okay? And in dialysis, you basically prolong the life of these patients with chronic kidney disease. So the longer you live, you can imagine the more cysts you're going to get. And that's why dialysis causes cystic kidneys. Okay? Nothing too difficult there. And that actually does it for our talk on cysts. Let's talk about neoplasms. Let's talk about cancers of the kidneys. And also we're going to talk about cancers of the bladder. 2 for 1. The most common cancer of your kidneys is called renal cell carcinoma. Renal cell carcinoma, or RCC. RCC. Now, renal cell carcinoma usually stems from your proximal convoluted tubule. That's an important fact to know. And it creates these clear cells full of lipids, full of carbs. Sometimes they call it vacuolated. A great picture will be in my notes. They like to invade the renal vein. If we remember, we talked about our gonads. Your right gonads is on the same side of your IVC, so it can hitch a ride right to the IVC. Your left gonads is pretty far away from your IVC, right? It's on the opposite side. So it says, hey, renal vein, can I hitch a ride with you? So it joins the renal vein and then crosses over. So your left gonadal vein actually joins your renal vein. So if you have left-sided renal cancer, it can invade your left gonadal vein, cause left gonadal varicocele, cause left gonadal metastasis. They love that question. All right. Something else you should know. This is associated with some perineoplastic syndromes. It can secrete hormones like EPO. What does EPO do? Increase red blood cell mass, so you get polycythemia. It can increase ACTH. Too much ACTH causes Cushing's. That's the whole moon phase, buffalo hump, all that stuff, all right? I'm not gonna get too far into it. PTH related peptide, similar to PTH. What does PTH do? Doesn't it break down your bone? Doesn't it increase calcium? So you get hypercalcemia, okay? And the last thing that you should know about renal cell carcinoma, if you see it on both sides, that's not normal. If you see it on both sides, that's not normal. If you see bilateral renal carcinoma, it's associated with von Hippel-Lindau. Now, if you've done my neuro videos, then you know I'm going to ask you, tell me everything you know about von Hippel-Lindau syndrome. If you haven't done it, all right, that's you get a break. But save this video and then come back when you have. What you do need to know is this is due to a deletion of a tumor suppressor. Deletion of tumor suppressor. And it can cause cancer. Because it's so severe, it causes bilateral RCC. Bilateral, that's the biggest tip off that something's not right. Now, when you're messing with tumor suppressors, do you only affect your kidneys? No, you don't only affect your kidneys, so you get cancer elsewhere. Okay, so you can get cerebellar cancer, you can get pheochromocytoma. But again, if you haven't done my neuro videos, I don't expect you to know that. If you have, then I do expect you to know that. That's RCC. Let's talk about another cancer. Kind of branching off VHL, there's another neurocutaneous syndrome called tuberous sclerosis. And that causes angiomyolipomas of your kidneys. I mean, what's in a name? Angio, blood vessels, myo, muscle, lipoma, fat. So you have a cancer of blood vessels, muscles, and fat. And on biopsy, you'll see all that. You'll see those big fat globules, you'll see muscle, you'll see blood vessels. And if they show you down on histo, I mean, that's easy peasy. Dead giveaway. Dead giveaway. Let's move on to our next one. Our next one is renal oncocytoma. Renal oncocytoma, it comes from your collecting ducts. And grossly, you have a mass with a central scar. So you have a mass with a central scar. Very easy to pick up. I had a question on it. They said someone had a flank mass, took the kidney out, saw this mass with a central scar. Where did the cells come from? Collecting duct. Easy peasy. I mean, there's only like 2 facts you need to remember for this. So that is probably the questions we want on our step. You know, really fast, really easy questions. Last but not least, we have Wilms tumor. The biggest fact you need to know about Wilms tumor is it happens in kids. Kiddos. Any kid with a solid flank mass that doesn't cross the midline, stays in the flank, and has hematuria has a Wilms tumor. All right, so it's very, very easy. All right, flank mass that doesn't cross midline. Flank mass doesn't cross midline. and hematuria, Wilms tumor. And the cancer is mostly primitive cells, so undifferentiated cells or primitive nephrons. Basically, something's gone wrong, and these cells are acting wonky, causing these early tumors seen in kids. About 90% of it is sporadic. About 10%, however, is associated with genetic mutations. Mutations in genes like Wilms tumor 1 and 2, what fitting names. And these are tumor suppressors. And if you have a mutation or a loss in these, then you get Wilms tumor. Now, when you affect tumor suppressors, does that only affect your kidneys? No. Why would it? It affect other places of your body. And so Wilms tumor is associated with certain syndromes. Let's talk about these now. Make some room. They found out that mutations in Wilms tumor 1 leads to something called WAGR. And that's Wilms plus a loss of your iris and iridia and genital malformations, genital malformation. The easiest way I remember this is just Wilms tumor 1 leads to basically Wilms plus malformations, either of your iris or of your genitals. Mutations in Wilms tumor 2 gives you Wilms, but also gives you hemihypertrophy, where one side's bigger than the other. And also gives you organomegaly, usually the tongue, so you have a really big tongue. They can't put their tongue back in their mouth, so organomegaly. I just remember it as Wilms tumor 2 causes Wilms plus some sort of bodily growth. I got a really cool question about Wilms tumor. It talked about a baby that was having hematuria, and they showed a picture of the kid lying down with a ruler next to it, and you can tell that one of their legs was longer than the other, and then they just kind of asked what's the cause of hematuria. You had to realize this patient had hemihypertrophy, one of the legs was longer, and that was due to a Wilms tumor. All right, so that one is very, very important. You're gonna have tests on it like in step 2 and then moving forward. So Wilms tumor, always ask in your pediatric rotation, so you gotta know well. That actually does it for all the cancers of your kidneys. Let's move on to your bladder. Your urinary tract epithelium is transitional, especially your bladder, transitional. That allows it to give a little bit of stretch. So transitional. And if you have cancer here, what do you think is gonna happen? It's gonna cause transitional cell carcinoma. All right, bladder. But it can affect other parts of your urinary tract, so just be aware of that. But usually your bladder gets affected. And you'll know it's your bladder and not like kidneys because it'll lead to things like hematuria, but it won't have cast. We said casts are only found in your kidneys. So if you see hematuria but no cast, and you know it's not dealing with your kidneys, it's probably dealing with your bladder. No cast. What are some causes? A lot of the causes are going to be carcinogens, so smoking, because smoking causes all cancers, right? Just those carcinogens. Cyclophosphamide, because it creates a toxic metabolite. Cyclophosphamide, you just always got to know. It can be from phenactin. That used to be a fever-reducing drug like acetaminophen. It just found out it was really, really toxic. So phenactin. You can have aniline dye, which is seen in rubber and dye. That's where it gets the name. It's just a carcinogen. Naphthalene, which is another dye and a carcinogen. And when you have these in your urine and they get to your bladder and they just sit in your bladder, they're just lying there in your bladder, just basking in your bladder, you get something called the field effect. The field effect. Where carcinogens bask, that's not scientific enough, cover your bladder and is allowed to sit there and kind of marinate. And because it's allowed to sit there, it creates different tumors at different sites. So it causes different tumors at the same time. They like the field effect question. That's transitional cell carcinoma. We have one more topic and we'll be all done. When you have chronic inflammation to your kidneys, then you can undergo metaplasia. This transitional cell carcinoma can become things like squamous, or it can become glandular. You can imagine chronic inflammation leads to hyperplasia, leads to dysplasia, leads to cancer. So squamous can become squamous cell carcinoma of your bladder. Some causes of squamous cell metaplasia and then dysplasia and then cancer is going to be chronic infections like chronic cystitis. Cystitis is common in women, again, because of their short urethras, they get infection more. So chronic cystitis can eventually cause metaplasia to squamous cell carcinoma. Another thing they like to ask is the microorganism Schistosoma hematobium. And this little bug, and this organism likes to live in your bladder and just causes havoc in your bladder, causes that chronic inflammation, that chronic infection that leads to metaplasia, SCC. So that's SCC. Let's talk about glandular. Cancer that comes from glandular epithelium is called adenocarcinoma. So you can get adenocarcinoma of your bladder. And again, it's due to chronic inflammation. It can be from cystitis. Some other causes that you should know, some important one is exstrophy of the bladder. This is a defect in your bladder wall where your bladder is actually outside of the body, exposed to the environment. And you can imagine if it's exposed to the environment, it can get chronically inflamed. That is a big one. Another cause is if you have remnants of your allanton. What the heck is that? That is a channel in your umbilical cord that helps you drain fetal urine. And if that remains for whatever reason, that's not normal, and that can turn into cancer. All right. And I think that actually does it for the cancers of your bladder, of your kidneys, and then we also talked about cysts, so that's a good pathology wrap up. Hope you enjoyed the video. Thanks.